glad that everyone could join in today. I will just start with a little caveat that when Anne asked me to do this talk, she also asked me to just share with everyone a little bit about my history and what I've been doing to give some background and context. So the first maybe 10 minutes, I'm just going to tell you a little bit about how I got to this point in my career and my interest in human milk and breastfeeding. So I actually think it's only fitting that we are here today together, because today is the International Day of the Nurse Midwife, and it is the first day of Nurses Week. As many of you know, this is the year of the nurse and midwife. I don't know that any of us really were expecting this is how we would be celebrating this momentous occasion. In 2019, I was honored by the Philadelphia Inquirer Influences of Healthcare Awards by being named as the Nurse of the Year. And that is something that I am very proud of, because I am passionate and committed to the profession of nursing.
At 15 and all of a sudden you're seeing that you're still spraying a lot and go up to 20 minutes, I wouldn't go.
Vital, could you mute? Thanks.
So I have been working on strategic methods to improve nurses' knowledge about human milk and breastfeeding for my whole career. This picture here of me is actually my graduation from the University of Pennsylvania School of Nursing. I had the pleasure of going there for all of my degrees, bachelor's, master's, and PhD, and I'm faculty there now. But when I graduated from the University of Pennsylvania, I had learned zero about breastfeeding. We didn't have a class, a lecture, no exposure at all. I myself was not breastfed as a child, so I had no exposure to it. And the hospital where I did my clinical rotation did not have any families who were breastfeeding. So I never even observed that in my clinical practice as a nursing student. I found my passion for mothers and infants, though, while I was at the University of Pennsylvania School of Nursing. And I immediately, upon graduation, went to work at Pennsylvania Hospital. Pennsylvania Hospital is our nation's first birthing hospital. This is a picture of the hospital here, and you can see the weather vane with a stork on it. So it is very famous for being a line-in hospital. This hospital is known for maternal fetal medicine. When I graduated from my undergraduate program, it was the height of one of the nursing shortages. My first weekend off of orientation, I cared for 9 mother-infant dyads. I was expected to help mothers be able to breastfeed. It was very, very stressful to me that I did not have the preparation or knowledge to be able to do so. Tammy Arbiter, who's pictured in this bottom right-hand corner, is actually one of the first IBCLCs in the United States. She was a lactation consultant at Pennsylvania Hospital, and I said to Tammy, you know, this is really uncomfortable for me. I thought I was a well-prepared nurse. How is it that I have no education or training in this? And I said, please help me. And so while I was at Pennsylvania Hospital working as a staff nurse, I also immediately entered into the master's program at Penn, getting a master's in perinatal education. I knew for sure that I wanted to work with pregnant women and their children, and I knew I really valued high-risk pregnancy. So while I was in that program, I was asked by Dr. Linda Brown to work on a research study about factors affecting milk volume in mothers of very low birth weight infants. And I was already working full-time in school, and this was just one more job to do. But when we did this research study, and to give you context, this would have been 1989, no one really cared about breastfeeding at this time, and mothers were not getting support. And so we were not even allowed to go into the hospital to collect milk volume logs. So I had to go to the mothers' homes in order to get their milk volume logs. And when I went, the mothers would pretty much want to lock me in the house to talk about their experience. And this just made me quite sad, and to stress that women were trying to do something for their child and not being cared for. So I went on to get my PhD right after my master's. I finished my PhD in 1995, got a faculty appointment at Penn, and had my first NIH grant funded. And in this grant, we used what is called the transitional care model at Penn, which has been widely published about, which uses advanced practice nurses to improve health outcomes. And so women were randomized either to receive routine care, which again, thinking about 1995, there wasn't much happening in terms of breastfeeding support, or intervention from advanced practice nurses. And we followed the mothers not only while the infants were in the neonatal intensive care unit, but also for 8 weeks post-delivery. As you can imagine, you give people good care, outcomes improve. And so being a new faculty and having this research grant, it was also really important that our students had access to evidence-based lactation support and care. So in 1995, I started the first ever course, undergraduate course on human milk and lactation for nursing students. This is a seminar course with 28 hours of lecture, 14 hours of clinical experience, and the students are highly engaged in the community in terms of breastfeeding advocacy, follow-up, and working with communities. The CDC has recognized my course at Penn as a best practice. And so this has been in place for 25 years, and we still have very few programs across the United States that address the needs that nurses and also physicians have for acquiring breastfeeding knowledge. In 2001, I was recruited to Children's Hospital of Philadelphia. Children's Hospital is a freestanding children's hospital. At the time, it was almost 500 beds. It's now probably closer to 600 beds. At the time in 2001, there was one IVCLC for the whole hospital, and there were 4 breast pumps for the whole 500-bed hospital. This is a picture of what our refrigerators and freezers look like at CHOP circa 2001 when I started. Clearly, you can see from the photos, there wasn't a high value placed on human milk. You can see the milk is not labeled, there's bottle nipples, there's even some milk in some urine specimen containers. So there was not a high regard for human milk. And the person who recruited me to Children's Hospital of Philadelphia, Peggy Gordon, she's the director of neonatal nursing. She's also past president of NAN, if you're familiar with the National Association of Neonatal Nurses. You know, she said to me when she recruited me, Diane, it will be a seamless transition in your research career. But clearly that was not going to be the case given the state of human milk and breastfeeding at that time. So what I started with was developing a breastfeeding resource nurse program. It is a 2-day course which nurses are paid to take, and they receive continuing education. We now have approximately 900 breastfeeding resource nurses at CHOP. It is a very different program, though, than traditional training related to the Baby Friendly Hospital Initiative, because in our situation, none of the children or babies we care for are normal. So the principles of BFHI are not really able to be implemented because our babies can't direct breastfeed at birth because of their complex medical problems. I also, at this time, established my 10-step model, which you heard about in my introduction. I knew and was very familiar with the Baby Friendly Hospital Initiative, but knew that it wasn't going to be something that was going to be really effective from us thinking about vulnerable babies or babies who are separated from their mothers at birth. And so this model has been in place, since 2004. We have extremely high human milk and breastfeeding rates with a 99% pumping initiation rate. And with the majority of our babies being born with us being discharged on human milk and breastfeeding. And this is important because, especially if you work in neonatal intensive care, human milk rates at discharge are considered a quality metric. So if you just take a glance of where Children's Hospital was, before I started, they had 1 IBCLC and 4 breast pumps and 4 pump rooms, and we had a very low human milk rate. And as you can see, our resources for lactation in terms of staff and equipment have significantly gone up. We also became our own milk bank in 2015. And so this did not happen by chance. This happened very strategically and working hard on methods to improve human milk and breastfeeding since my recruitment there in 2001. I've also had a long-standing passion in addressing health disparities in breastfeeding. And I worked with Dr. Linda Pugh on this research study funded by the NIH about low-income women, primarily African-American, in East Baltimore. And again, we used the transitional care model, but in this case, we used a nurse and a peer counselor. We only did 4 interventions at the time of discharge from the birth hospital at 7 to 10 days post-discharge and at 4 weeks out. And with that intervention, we statistically significantly increased breastfeeding rates at 6, 12, and 24 weeks. And this was for a group of all low income, almost all African American families. So we have data about my model and how it works from both the US and around the world. We have a publication that will be coming out very shortly in Breastfeeding Medicine about implementation in Japan. And I'll come back to this a little bit at the end of my talk. So this year in 2020, we come to today and the focus of our talk. And it's hard for me to believe that it has been 25 years since I got my PhD. It really has gone quite quickly. So I'm very excited today to talk about national and international guidance surrounding COVID-19 and breastfeeding. I'm going to talk about the role of shared decision-making, and we're going to ensure for the protection of milk supply. So I want to start with the local media story. This was on the Philadelphia area news, where they interviewed a family. The mother had 2 older children that she breastfed, and she had twins who were in a local NICU, not top, but a local NICU. Since the COVID-19 pandemic started, both her and her partner were not able to go to visit the twins. They restricted visitation. So the mother, her goal was to breastfeed her twins, but she was not allowed in the hospital to see them. All she was allowed to do was to drop off her milk at the curbside. And so when we think about this, what is the human rights of both that mother and those children, of them not being able to be together during this pandemic? And what is the role of shared decision-making between both healthcare providers and parents? So as you heard in the introduction, I was recently elected to the executive committee of the International Society for Researching Human Milk and Lactation. They do have a beautiful website with current guidance. And I actually really recommend this to everyone because what they have done is they developed a collated database of publications. And so there are international guidance on the website, as well as an Excel file that has the PubMed ID and all of the articles that have been published on this topic specific to human milk and pregnancy and lactation and COVID-19. Many of my colleagues are also working on really how we can best collect the milk and study the milk. And I am working on a collaborative agreement with Dr. Lars Bodie out in California so that we can also study the milk. So this is a very important and exciting resource for you all to use. So starting with international guidance, UNICEF really enforces how critical it is for mothers to breastfeed. And I really like their statement, considering the benefits of breastfeeding and the insignificant role of human milk in the transmission of other respiratory viruses, the mother can continue to breastfeed while applying all necessary precautions. So really emphasizing that early exclusive breastfeeding and skin-to-skin contact. The World Health Organization also has come out very strongly about the importance of COVID-19 women being supported to breastfeed, to hold her child skin to skin, to share a room with her baby, and that importance of early exclusive breastfeeding. Again, emphasizing safety, that when women breastfeed, they should practice respiratory hygiene, they should wash their hands before and after holding the child, and making sure, of course, that they are routinely cleaning and disinfecting surfaces. The World Health Organization goes on to really also focus on that provision of human milk. So if for some reason the woman with COVID-19 is too unwell to breastfeed, she should be supported with expressing milk. We also have seen a growing interest in relactation for women who had prior stopped. And we also want to acknowledge the role of pasteurized donor human milk. Not that it is a replacement to mom's own milk, but a potential bridge. But one of the most important things we can do is really ensure that we are protecting milk supply during this pandemic. And I have an article that will be out shortly about this topic. The United Kingdom also endorses the recommendations given by both the World Health Organization and UNICEF, supporting early exclusive breastfeeding and, again, appropriate respiratory hygiene and washing and cleaning surfaces. So I think we have a lot of great support internationally for the use of human milk and breastfeeding. As you all know, Italy was a country that was extremely hardly hit with the COVID-19 pandemic. They have some beautiful guidance from the Italian Society of Neonatology and endorsed by the Union of European Neonatal and Perinatal Societies. And they recommend early exclusive breastfeeding, and also in the case of maternal infant separation, really endorsing that use of human milk if direct breastfeeding is not an option. Interestingly, China has been the only country that came out with national recommendations to endorse formula feeding. And in China, they were separating mothers and children. They were actually delivering mothers via cesarean birth, separating moms and babies. And even with their strict separation policies, it did not prevent some infants from developing COVID-19. I think this case study that was published is very interesting because it was a case of a mother who did choose to breastfeed, even though the China advice was not to. And they were able to detect the antibodies in the milk, and there was no detectable virus in the milk. So I think we have to take the recommendations from China with caution because they are a major producer of formula. They export a lot of formula all over the world, and they do have a predominantly strong formula culture. So moving to the United States, the Centers for Disease Control and Prevention in the beginning came out, talked about the importance of human milk, talked about the fact that the virus has not been detected in human milk, and talked about supporting direct breastfeeding with appropriate precautions as well. They have since given some updated considerations in terms of prioritizing testing of mothers, the isolation of potentially COVID positive infants from other healthy infants, and then really, again, thinking about should maternal infant separation occur, and that each family and her healthcare provider should be making decisions on a case-by-case basis using shared decision-making between the mother and the clinical team. The Academy of Breastfeeding Medicine has their policy statement, which clearly states that it is the mother's choice to breastfeed. If she is well and has only been exposed or is a person under investigation with mild symptoms, breastfeeding is a reasonable choice. Again, they really emphasize the importance of both human milk and breastfeeding, and they further state at home that COVID positive individuals should be in home isolation from other family members, friends, neighbors, including the infant, except for in the case of breastfeeding, that direct breastfeeding is recommended. The Academy of Pediatrics is the only professional organization who has really come out strongly about the separation of mothers and infants after birth. And so their rationale is that this temporary separation will minimize the risk of the infant being infected from maternal secretions. Again, we have to be somewhat concerned because we know that to date, the virus has been not detected in human milk. So we have to support the mother in her ability to either express milk or feed that baby directly at the breast if that is her request. They also provide further guidance on intensive care, keeping the baby in a negative pressure room, or cohorting multiple infants together. Again, supporting the use of human milk in all cases. They do recommend testing, first at 24 hours of age, again at 48 hours of age, unless the infant has been discharged. So I think one of the things that is important is in some birth hospitals in my area, they are testing mothers, but not testing infants. They're not fully following the pathway. So you see a lot of hospitals doing lots of different things, and perhaps not following any of the national or international guidance. American College of OBGYN, again, supportive of human milk and breastfeeding with appropriate precautions. I saw in the introduction you're going to have a panel at your next session from the Academy of Breastfeeding Medicine. But Allison Stubbe, who is our current president, wrote this commentary about doing no harm. And her commentary addresses the following 5 factors. As I mentioned already, separation does not necessarily guarantee a prevention of infection. We interrupt skin to skin, which disrupts newborn physiology. It creates stress for the mother. It disrupts the microbiota, which is really important to acknowledge. And if we separate the mother and child and we need 2 different caregivers, that means we also need double resources and double the PPE. So, what can we take from all of these recommendations? We can take the fact that despite the conflicting recommendations from professional organizations, all of them support the use of human milk. And you know, this is in the media and families are concerned about this. I mean, it was in the New York Times. And so we have to imagine that families may be absolutely stressed and concerned at this time from the conflicting information they're hearing from friends, from family members, from healthcare providers. So what can we do to support human milk and breastfeeding? So we already know that in the United States, the current practice paradigm isn't really ensuring that all women meet their personal breastfeeding goals. We have suboptimal breastfeeding rates. Even though our initiate rates are increasing, our exclusive breastfeeding rates at 6 months are still only at 25%. And as I'm sure you are well aware, we have tremendous geographic and racial and ethnic and income disparities. And so this concerns me greatly because what we are seeing is that with COVID-19, we are seeing that the rates of COVID are higher in our low-income families. We're seeing high rates of COVID in African American and Latinx families. And so we have families who are at risk for not breastfeeding and are at risk for COVID. And I'm really concerned about what is going to happen with these families if we're not providing them with appropriate evidence-based breastfeeding support and care. In Philadelphia, and I'm sure in other parts of the United States, you have seen families struggling to be able to find formula. We have had price gouging where the prices of formula have been increased 5-fold in supermarkets in our area. Our families don't have the resources they need to be able to access the formula. So what can we do about this? We have got to message these families, all of our families, before they ever deliver about the important value of human milk and breastfeeding. I see patients still today, and all virtually, as my role at Children's Hospital of Philadelphia. And one of the first things we discuss is about the importance of human milk and breastfeeding as a protective entity for critically ill babies, which we care for at Children's Hospital of Philadelphia. The United States Breastfeeding Committee, as you heard on the introduction, I serve on that committee, and they have developed a COVID-19 response task force, and they promote breastfeeding in events of emergency, including COVID-19. So I wanted to share this story because families are worried about food and money and the economics. So when the pandemic was really coming to light in our region in Philadelphia in the beginning of March, one of my colleagues who I've supported through her breastfeeding journey, she sent me this text, and she said that her mother was very concerned because offices were closing, people were having to work from home, schools were closing, and she asked her daughter, "Do you have enough food for Sally?" And my colleague here is pointing at her breasts. And so she sent me this picture because she knew I would appreciate it. And certainly, if families have made the informed decision to provide milk for their child and breastfeed, we don't have to worry about that. And this is actually a picture of her daughter from Easter Sunday. And she sent me this picture and she said, "Happy Easter from the Keister." And you can clearly see that this little baby is thriving with her chubby cheeks and her chubby legs. So we don't have to worry about infants thriving if we have families breastfeeding. So this article is actually out now, available online, thinking about using this pandemic as an opportunity to really highlight and elevate the critical role of human milk and breastfeeding as life-saving medical interventions. We have to, though, ensure that we are preparing all families equally. All families need to learn the science of human milk. They have to understand the physiology of lactation. And we also have to ensure that families understand that it is going to be hard, maybe. It's going to take time and work and effort and commitment in order to be able to provide milk for their baby, especially if they end up getting separated at the birth hospital. So we have to give them appropriate prenatal anticipatory guidance. So what about the shared decision-making? Okay, the Agency for Healthcare Research and Quality has really great information on their website, and they actually offer a full one-day training about shared decision-making. Okay, so in shared decision-making, healthcare providers and patients work together to make healthcare decisions that are best for the patient. So women have to, and families have to, use their voice about their desire to breastfeed their babies. In the SHARE approach, there are 5 easy steps. As a healthcare provider, we have to ask the patient their preferences. We want to have the patient participate. We want to help the patient explore and compare treatment options. We want to know or assess the patient's values and preferences. We want to reach a decision with our patients, and we want to evaluate this decision. And in this state of the pandemic, we do know that the virus has not been detected in human milk, and all the information that we have about human milk and breastfeeding being important for both mother and child and society, we must acknowledge. So we can take my model that was initially developed for vulnerable infants who are separated from their mothers at birth because of being preterm or having congenital anomalies, and we can apply these principles to the current pandemic. We're going to focus on just the first 3 steps as being critical messaging components for our families during this time of COVID-19. As I mentioned, we do have evidence from both the United States and globally that this approach works to improve human milk rates at discharge when we have critically ill children. So I already mentioned health disparities, and we know that in the United States, many people do not initiate breastfeeding due to their culture, due to a lack of family support, a lack of education, or a lack of exposure to breastfeeding. So if we think about this young lady here, on paper, people would probably think she wouldn't be a breastfeeding mom. She was 16 at the time of her delivery. She was low income, African American. She came from a family where no one had breastfed. Yet this young lady was one of my patients, and she provided exclusive human milk for her child for 5.5 months, even after going back to school. So we developed a DVD at Children's Hospital of Philadelphia called The Power of Pumping. It is a DVD that focuses on the science of human milk as a medical intervention. I believe it's really important that families understand what human milk is. If you in your clinical practice don't currently ask families what they know about formula or about human milk, you are doing a disservice to them. When I have a family who says to me, I am not interested in breastfeeding, I explore why. And one of the first questions I also ask them is, what do you know about infant formula? And many of them have no idea what formula is made from. So I teach families about the science of human milk, about human milk oligosaccharides, antibodies, antioxidants, lactoferrin, osteopotin, white blood cells, stem cells, all of these ingredients that are not present in any infant formula. And we can't talk about all of them today, but I do want to just briefly talk about human milk oligosaccharides. Dr. Lars Bodie is a good friend and colleague of mine. He's in California. He has dedicated his life to understanding these human milk oligosaccharides, which are prebiotic, they are probiotic, they're antimicrobial. They are not digested as they go through the infant system. So they are there to protect the infant. They are very powerful. And what we know is that mothers tailor human milk oligosaccharides to their infants. So no two mother has the same profile, and the child gets specialized programming directly from his mother. So Lars has received funding in his lab to study human milk and COVID. And I am working with him as a collaborating center to look at mothers who have been exposed and that presence of both the human milk antibodies and the absence of the virus in human milk. And I love this quote from Lars, which I asked him if he would share a quote for me. And he said, I'm most excited about this line of research as it might once again show the true power of human milk in helping us fight this darn virus. This study that was published on April 15th is not specifically about COVID, but it's a very important study because they looked at multiple human viruses and they found that the viruses were more abundant in stool samples of exclusively formula-fed babies than those who got partial human milk or full human milk. So there's a dose response benefit. So even some human milk is better than not any at all. So we want to ensure that a mother can effectively establish and maintain her supply. Again, in this time of COVID-19, where some hospitals are separating the mother and the child, we have to ensure that she can effectively come to volume, which means we need to teach the mothers while they are pregnant that they are making milk. I just had a consult this morning with a mother. She was having her second baby. She was worried that she wasn't going to have enough milk for her baby. And I said to her, you have been making milk from 16 weeks of pregnancy. You're now 37 weeks. So your breasts have had 21 weeks of practice already. So there's no reason to think that your breasts are not prepared and ready to make milk. How many of your families worry about milk supply, right? This Vatican statue, she probably has no concerns about her milk supply because she's got quite a few breasts there. But almost every breastfeeding family that I meet has concerns about milk supply at some point. We have to remember, and families have to understand, that colostrum is present in very small amounts, and it's there for a specific purpose, to lay down that baby's immunobiological system. We have a critical window to ensure that the mother comes to full volume. And if we don't effectively stimulate and empty the breast at this time, we are going to jeopardize the mother's milk supply for the long term. We have data for preterm and term infants that really supports that there's a critical window to come to volume. We have to focus on that early first hour, first day, and the first 3 to 5 days. So the mother's most important job is going to be able to eat and sleep and make milk for her baby. And we need to mobilize both family and community support. Now, what family and community support in light of COVID-19 looks like is going to be very different because we don't have extended family and we don't, in some cases, have in-person lactation support. So we're going to have to turn to telelactation and online platforms. If the mother and infants are separated, we really have to ensure appropriate technology. Personal use pumps, such as those that mothers get from their insurance company, are not designed to establish milk supply. They are designed for mothers who are breastfeeding already effectively and going back to work or school. They're not designed for the mother who's initiating lactation. The research is crystal clear. There is a critical window to effectively establish milk supply. They're going to need to pump early and often with the right technology if the healthcare providers or the hospital has made the decision to separate mother and child. And we need to ensure that the mothers have come to volume by day 5 after delivery. So that first pediatric visit is going to be critical. Many times I hear the argument that our low-income families can't afford the cost of a pump. At our hospital, we actually are our own rental station and we do rent hospital-grade pumps. And if you think about the cost of a pump rental and you compare it to the cost of infant formula, and that's without price gouging, okay, a cost of even a hospital-grade pump rental is significantly less than the cost of infant formula. If the mother has to express, again, I endorse and support direct breastfeeding at the breast. But if she's been separated or if she does have a critically ill baby, then we have to give her appropriate guidance for pumping. She needs to have guidance for pumping, labeling, storing, washing, and sanitizing equipment. The CDC offers guidelines for pump cleaning, both in English and Spanish. I've also heard very interesting things about healthcare providers being concerned about handling of human milk. This is guidance from our infection protection and control at Children's Hospital Philadelphia. There is no need to wipe down the bottles of milk. The main recommendations are proper hand hygiene, both before and after pumping, cleaning of the pump and the pump kit, and then wearing of a mask if the mother is symptomatic. So the last step I want to just talk briefly about is human milk management. because in this time of COVID-19, we want to prioritize the use of fresh human milk. It would be ideal if the mother was feeding directly at the breast, but if not, if she was separated, having her pump and store the milk for up to 4 hours at room temperature or up to 4 days in the refrigerator. Once we freeze human milk, we destroy the white blood cells, we destroy the stem cells. And many of the immune components, lysozyme, IgA, lactic peroxidase, are not as effective. Okay, so we really want to have families understand the most important thing they can do is provide an exclusively fresh milk diet for their child. If mom's own milk was not available, pasteurized donor human milk would be a better choice than formula, especially for that hospitalized infant. Children's Hospital Philadelphia, we are our own milk bank. We use donor milk for a variety of infants, including preterm infants, infants who have intolerance to formula, surgical infants, and we also use it for parental preference. Again, in our context, we are never using pasteurized donor human milk as a replacement to mom's own milk. It is merely a bridge if we did not have enough. In primary care, in the pediatric practices, our recommendation is also to continue exclusive direct breastfeeding. This is not the time to consider weaning. When people ask me about, oh, my daughter's turning 1 in May, I'm kind of tired of breastfeeding, do you think I should wean? No. If the mother is currently tandem breastfeeding more than one child, the answer is no, okay? This is the time we really want to encourage mothers to continue their breastfeeding journey. Breastfeeding is a life-saving medical intervention. It can happen anywhere, anytime. It is always ready. This is a personal friend of mine who had her child in Switzerland right before the pandemic happened. And here you can see how important human milk is for the reduction of maternal stress and helping children to thrive. You can see that this beautiful little boy, Ari, he is clearly thriving from exclusive human milk, exclusive breastfeeding diet. Human milk is a powerful intervention. My last case I'll share, and then we'll have times for questions, is the case of baby Charlotte. She was prenatally diagnosed, her mother, with a giant omphalocele. So her mother knew before she delivered that her baby would need surgery. I met with her mother prenatally. She learned everything she needed to do. She was a very diligent mother, and she pumped early and often, and she made over 1 liter of milk a day. Her baby needed 8 surgeries, was not able to direct breastfeed until about 4.5 months. And this is baby Charlotte at 1 year, and she received 100% human milk. And I really think it's critical for us to change the prenatal care paradigm in order for us to improve human milk and breastfeeding outcomes. We have to empower families in their right to breastfeed and their right to be able to effectively feed and provide for their child. The mama made so much milk, 1 liter a day for an entire year, that she was also able to donate milk to the milk bank. And so we have stayed in touch over the years. She had been a speaker for me when we opened our Human Milk Management Center at CHOP. She spoke for me when we opened our milk bank. And this is the mother and child today. So Charlotte is perfect, beautiful, healthy, smart, gifted, no health problems at all, despite a very long stay in our CHAP NICU. And her mother had an experience that was so positive that when the Human Milk Banking Association of North America was looking for a new executive director, I told Lindsay, you are the person who must take this job. And I was very happy that they did hire her in that position. And so all of the families have allowed me to share their stories and their pictures. And I hope that we all can think about the fact that we're in a challenging time. But the one thing that we can continue to do is to promote, protect, support, and provide evidence-based lactation support and care. So thank you.
Diane, thanks so much for that. That was a wonderful presentation. Let me just put my screen back up. That was just wonderful. We had a very, very active chat there, very active. I'm just going to pick out a couple of things that I saw in the chat that came up. One is, and this has actually come up in other places, in terms of cleaning breast pumps. I actually was talking to the national people at WIC yesterday. I don't think that there's any guidance that I've been seeing that's coming out about whether you should clean breast pumps differently in this situation. A few people asked about that in the chat. Do you have any information on that?
So, I mean, we've discussed this with our infection protection and control. I mean, it's the standard care that you would do. I mean, it's appropriate hygiene at all times. So, you know, we're using hospital grade pumps because we have critically ill babies. So the practice is that, and it's the same practice that it has always been, that we wipe down the pump in full outside with a hospital approved cleansing wipe. So like an Oxford wipe, we wait for the pump to dry. Mom washes her hands, good hand hygiene, and then she assembles her pump. And, you know, we have forever been very obsessive compulsive with our families and really teaching them about appropriate pump cleansing. And I know that doesn't necessarily happen everywhere. And I've heard even like working moms do things like, you know, they put their pump pieces in the refrigerator and stuff to save time. But, you know, really important to wipe down the pump, good hand hygiene, and then appropriate cleaning of the pieces.
Thank you. Before we move on to anything else, any of the people who asked about pump cleaning or anything, if you wanted to add anything, we've got a lot of stuff in the chat. So you wanted to ask anything additional on that, you could unmute yourselves and just ask us directly. If there's anybody, I'll give a couple of seconds for that to happen. No? Okay.
And this is Tawanda.
I'm sorry?
This is Tawanda.
Go ahead, Tawanda, yes. Tawanda,
Hey.
by the way, Diane, is works with CHAMPS, and she's also a WIC regional leader in Mississippi. Go ahead, Tawanda.
Oh, thank you so much for what you do.
Thank you. You're welcome. Well, with our agency, we decided to stop giving our hospital grade pumps and to only give the single user pumps, even for moms that are in the, you know, have babies in the NICU. And I know you said that they're not effective at establishing the milk production and everything. So, and the main reason was because of the product they were using to clean. We don't have those hospital grade approved cleaning products. We were only using cavi wipes.
Mm-hmm.
And we didn't have clearance that, you know, it could be a disinfectant for the COVID-19. So that's why we, you know, decided, my state, you know, central office level personnel decided that we would only give the single users.
Yeah, the same thing happened in Philadelphia, unfortunately. They had made that same decision. So it could be something that has happened across the whole US. You know, when you think about how long COVID can live on a surface, you know, if you look at the different surfaces, the longest is like 4 to 5 days. So the one option I had always thought about considering too is that if you know, were very worried, you could, you know, clean down pumps, and then you could also let them sit for 5 days before, you know,
Okay.
using them for another family. But I do understand that concern. I think the other thing, Tawanda, would be encouraging your families to spend as much time they can in the hospital and pumping with a hospital grade pump, hopefully at their child's bedside. And
Yeah.
then if they're, you know, using your personal use pump just part-time, then
Mhm.
that should hopefully help sustain them. But I think
Okay.
the one key message for your families too, Tawanda, is because there's that critical window in that first hour, the first
Yeah.
day, the first 3 to 5 days, your WIC mamas are still gonna be in the hospital at that time. So
They
they're
will.
gonna have access to the hospital grade pump at that point. So
Yeah.
that's gonna help bring their volume up,
Okay.
right? And so if they're pumping 6 times a day with a hospital grade pump visiting their baby and only having to use the personal use pump once or twice at night, overnight, then, you know, that might be okay. It's not
Okay.
ideal, but
Yeah.
it's better than them just having to use their hands or something like that.
Exactly. Yes. Thank you.
You're
Diane,
welcome.
we're almost at we're at 2 o'clock, but Diane kind of agreed to stay on a bit longer. So I do want to put one question here, which came up early during the webinar, and I think many of the people I know are on this webinar who are nurses, regular nurses on regular units in Mississippi. Do you have any specific tips for how people like that? I understand what you've been telling us, that we need to educate people in advance, etc., etc. But say you're a nurse right now on a unit where they're not really that supportive of breastfeeding, but you are, and they're being told to separate, and they don't really necessarily have a lot of individual power, these nurses. Any tips you can give those people?
Yeah, I mean, I feel, let me just start by, I acknowledge and feel their pain, okay? Because we're seeing this in birth hospitals in our region too. And we're actually experiencing the fallout of that in our pediatric primary care practices, because moms and babies got separated and then they come to their first newborn visit and mom's supply is already compromised. So I just want to acknowledge that I feel their pain too. So I think I always go back to science and really focus on the science of what we know about human milk. And when we think about the fact that human milk is a living, changing organism, when we think about human milk having white blood cells and stem cells, and you know, we know that if we take viruses and inject them into milk, that milk can destroy many things, right? And so I would try to have nurses try to think about how they can really help their families be rooted in science and evidence, and understand that we might not be able to change decisions that some healthcare systems have made, but what we could do, even if maternal infant separation has happened because that's been the hospital mandate, we can make sure that that family knows the value of human milk, and we can help that family effectively get started with milk expression immediately after birth and immediately in that postpartum stay, because the programming aspect, right, the physiology of milk production, it's so clear. You know, if the biomarkers, if we don't convert that mother effectively in that early 3 to 5 day period, she's going to be set up for suboptimal milk production for the rest of her lactation experience.
Thanks. One more question, and this came up, and you mentioned at the beginning how there was a set of twins whose mother wasn't allowed to visit them, and Laurie Feldman-Winter put into the chat here, how is CHOP handling the COVID positive mothers or other parents in terms of coming into the intensive care unit for babies?
So the good news is, for us, we have had very few COVID positive mothers at this point. I'm gonna knock on wood that it stays quiet. But we, our standard of care, even before COVID, was to encourage early, frequent pumping, because we have all mothers who have sick babies. And so we are also if a mother comes from like a community where there's been a high rate of COVID, we're actually asking the family to move to our area and to a hotel earlier, and making sure that she's kind of isolated 14 days prior to delivery.
Oh, that's interesting.
Yeah, and so we've always worked with like host family homes and Ronald McDonald House, and we've worked with hotels, and we've kind of opened everything up to make sure that families are getting getting that transfer to our area quicker, and hopefully minimizing exposure. So I think I feel very happy with how we've been handling the situation. And so if the mother is febrile and symptomatic, we are having a period where she has an interruption from seeing her baby, but we want her expressing, and then visiting her baby when her fever has resolved.
We also had a comment from Vivian Falk in the chat here saying that she works in an NICU. They have mums wipe off the breasts prior to pumping, and then express milk in the bottles gets put into Ziploc bags, take it to the NICU, and then the bedside nurses wipe the bags down prior to taking bottles out. This is for women who are already COVID positive. Any comment or feedback on that?
I know a lot of places are wiping down milk. I've heard this time and time again. I guess for me, we know that COVID could be on any substance. Like it could be on a bottle of formula. Like a mom could sneeze onto a bottle of formula and the COVID could be on that, right? She could cough onto formula and it could be on that. So I mean, if people want to wipe down the milk, that's great. I would really make sure that we're not using something that would be dangerous for consumption for the infant. But our infection protection and control said it's not necessary to wipe down.
Oh, interesting.
The part about wiping of the breasts, I think people are doing this because they're concerned about the mom's respiratory secretions and like she could cough onto her breath. I think about respiratory hygiene, the wearing of the mask. If we're wiping down breasts, we're also destroying microbiota. And so when I think about the importance of early direct breastfeeding, exclusive breastfeeding, we know that moms and babies who breastfeed, their microbiota stays in sync. So when we separate moms and babies and we express milk, that's already disruptive. And so, yeah.
I think the WHO recently came out with revised guidance about skin to skin, and they said don't wipe the breast.
Exactly.
Go ahead.
No, I have a hard time thinking about that being a good practice.
And Alicia just made a note. Alicia Zook said a mother should wear a mask while breastfeeding. Is this true? I would say that would be true for a COVID positive mother, right?
Correct.
Not for mothers, yeah.
Or a person under investigation.
Yes. So we've got this recorded and we're going to be putting it on our YouTube. We don't want people to take Diane's pictures off the slides, but our recording is basically a straightforward recording. It's not the PowerPoint presentation, and that will be available on our website. So at this point, does anyone have, I think we've gone through most of the things that were actually questions in the chat. There was some reference to the fact that WIC clients get free formula, and therefore the cost of formula versus the cost of breast milk. Then we had a great deal of chat about that, because of course not all of the formula is paid for by WIC, etc. So I don't think we necessarily need to get into that, but is there anything else? Well, do you want to talk about that at all, Diane?
I would like to just state, and there was a study done, it's probably a decade ago, that looked at how much extra money women had to spend to buy formula, because the WIC formula doesn't take their baby the whole time for the first 6 months. And they found that WIC moms had to spend an additional $46 a month on the purchase of infant formula. So again, if you do the math on that and you round that up, to $50 a month, probably even more than that at this point of time, that is not an insignificant cost for our families. And right before COVID happened, I was in Botswana, and Botswana is a country that was, you know, devastated by HIV. And when that happened in Botswana, you know, the federal government started giving out free formula. And now, even in 2020, formula is still the predominant cultural norm. And we know today that, you know, in a country like Botswana, early exclusive breastfeeding is absolutely essential even in the presence of HIV. And so, you know, the harm we can do in promoting formula use just to be on the safe side makes me super nervous.
Yeah. I will say, Diane, you probably are seeing the chat, but we have loads and loads of great. Thank you, Diane. Thank you, Diane. Thank you for this webinar. Thank you for your work in breastfeeding. Many accolades, which are definitely well deserved. Well, thank you very much. Thanks for your time, Diane. It's always great to have you. You always speak wonderful, entertaining stuff, and very, you know, it's very heartening, you know, to know that in a place like CHOP, where you have such severely ill children, you're able to do this and promote it. You know, the rest of us should be able to do it with the healthy ones if you can do it with the ones.
It's always my argument that if we can have our babies get human milk and breastfeed, that, you know, everyone should be able to do that. And we're actually doing a study right now. It's actually, a lot of my research projects have gotten halted because of COVID, but this one is actually all done just via the phone and virtually. And we're doing a follow-up of how long our mothers continue to breastfeed post-discharge. And I mean, the rates of breastfeeding are unbelievable, with, like, you know, something like 80% of them still breastfeeding at 1 full year. And this is, you know, kids who are critically ill and on ECMO at birth.
Well, you know, and I think part of it is when people, and this is very relevant to the current situation, when people realize that the importance of breastfeeding in an emergency, whether that's their individual child that's going through an intense emergency or the whole world that's going through emergencies, you know, that is what we want people to recognize, that effectively the healthy children need this too, and we all need to be able to do it. And maybe, as you've said, this is the time to sort of get that message out there. When else could we make our point more, and when else could more children benefit from breastfeeding than in this emergency? So thank you, everybody. We'll wrap it up now. We've still got over 100 people on the webinar, but thanks so much, and thanks for your time, and thank you, everybody. And please come to the webinar next week as well. So we'll talk then. Okay, thanks all. Bye-bye.
Thank you.
Bye-bye.